Uh, Good morning and a warm welcome to our esteemed doctors who have for today's focus group discussion. Uh, and a warm welcome to everyone for this. Before we go ahead, we just want to reiterate Abbott's motto, that is life to the fullest. And it is Abbott's endeavor to collaborate with gastroenterologists all over the country and across the country to bridge the need gap in the therapy area of gastroenterology, which we are present in. So before we go ahead, I'd just like to showcase a small video which details the excellent manufacturing practices and the standard of the quality which we maintain at our manufacturing plant.
Our mission at Abbott is to help people live healthier through our life-changing products. When it comes to helping people live healthier, every detail matters. This commitment is stamped on every bottle, strip, tube, carrying the Abbott mark. A mark of diligence. A mark of rigor. A mark of precision. A mark of skill. A mark of purity. A mark of consistency. A mark of high quality and trust. And we ensure such quality standards not only at our own manufacturing plants, but also with the people we work. A mark with the power to shape lives. A mark that puts the people we serve at the center of everything we do.
So thank you. Now we are moving into the topic proper for today's focus group discussion, that is the role of alginate in various profiles of acid reflux. I'm taking great pleasure in introducing our chairperson for today's session, Dr. Vedant Karvir, who is a renowned gastroenterologist known in the area of Mumbai. Sir, Dr. Vedant is currently the director and chief gastroenterologist at the Globus Gastroenterology Hospital, Malad, Mumbai. Dr. Vedant started his private practice in the year 2014 after completing 3 years of training in gastroenterology from the renowned KEM Hospital, Mumbai. And in 2018, he was awarded the fellowship of American College of Gastroenterology, that is FACG. Till date, Dr. Vedant has done more than 20,000 endoscopies, which also includes the therapeutic endoscopies. A warm welcome to you, Dr. Vedant, for this focus group discussion.
You for the kind introduction.
Uh,
You
and
want me to begin?
Sir, I'd also like to introduce our esteemed panelists for today's session. We have Dr. Alok Kumar Mantri, sir, who is from the Blue Wheel Hospital, Bhubaneswar, or Dr. Manni Gautam from the Max K. Sai Tirumala Super Specialty Hospital, Narsarapet. Then we have Dr. K. Somshekhar from Senior Consultant Gastroenterologist from Yashoda Hospital, Hyderabad. We have Dr. Ashish Tapadia from Dev Kamal Liver and Gastro Case Center, Akola. We have Dr. Swapnil Walke from Sparsh Hospital, Solapur. Dr. Siddharth Kanta, consultant gastroenterologist hepatologist from Kalburgi. Dr. Srikant Makam from consultant gastrosurgeon from Sri Markandeya Sarkari Rugnalaya and Research Center, Solapur. Dr. Amit Gulane, consultant gastroenterologist from Alexis Hospital, Nagpur. Dr. Darshil Shah from Mumbai Gastro and Liver Care Clinic, Mumbai, and Dr. Manoj Kumar, consultant gastroenterologist from Savera Institute of Medical Sciences Private Limited, Anantapur. A warm welcome to all the panelists to this focus group discussion. Coming to the main objective of today's FGD is to discuss the role of alginates in various profiles of acid reflux, that is mainly postprandial reflux, nocturnal acid reflux, refractory GERD, and acid reflux in pregnancy. Just a small recap on agenda of today's session, which has already been discussed over phone with you and also over mail. We'll be having the opening remarks by the chairperson, Dr. Vedant, and followed by that, we have Dr. Alok Kumar Mantri, who will be talking on the postprandial acid reflux, mainly talking on the postprandial acid reflux with focus on the acid pocket and the role of alginates in postprandial acid reflux. Then we'd be having a poll question of anonymous poll questions of five. Followed by that, we have nocturnal acid reflux as second topic by Dr. Manne Gautam, mainly looking at the GERD mechanisms during sleep and the role of alginates in it. Then we have Dr. K.S. Somsekhar also talking on the refractory GERD. What are the unmet needs in management of GERD? Management of GERD in refractory to PPI and the role of alginates in it. And the last topic is GERD during pregnancy, which is mainly understanding the acid reflux during pregnancy and the use of alginates in it. Followed by the talk, we'll be having a concluding remarks from our chairperson, and we'll be closing the session. Now, without much further ado, I request our chairperson, Dr. Vedant, to take over the session and set the ball rolling. Over to you, sir.
Thank you.
Just a small request to all our panelists. I'd request you to switch on your cameras so that it will be a more interactive session.
Good morning, everyone. So, as most of us are a well-established practicing gastroenterologist, we all know that GERD is still the main referral for all of us. And to my personal experience, almost like 50 to 60% of patients, especially in the private clinical practice, come for GERD. And when we talk about GERD, it is not only the isolated form of GERD, but it's sometimes that GERD is combined with features of irritable bowel syndrome. Sometimes they are coexistent with other diseases like IBD or pancreatitis, sometimes even cirrhosis of liver. So we also come across a lot of particular things which we see in the patients with GERD. So the point of today's discussion will be that we all gastroenterologists will have a discussion about what are the particular situations where our practical experiences can help us make better decisions for these patients with GERD. So all of us are aware with the Montreal cluster, the definition of GERD, where it is a reflux or backflow of the stomach contents, and which results in the unpleasant symptoms and sometimes complications. So today we will be discussing on the postprandial reflux and refractory GERD, nocturnal GERD, and GERD during pregnancy. So we have good four speakers who are going to discuss on this. Dr. Alok, who will be discussing on the postprandial reflux, and Dr. Mani Gautam, who will be discussing on the nocturnal acid reflux, and Dr. Somsekhar sir will be discussing on the refractory GERD, and Dr. Alok sir will be discussing on GERD during the pregnancy. So hope we have a very nice discussion for this. There are four factors which we encounter on a regular basis. So GERD, when should it be taken seriously, or whether we can have a casual approach? Because most, as I said, maximum referrals are for GERD. The current data says that almost 10 to 20% people, adults, suffer from GERD, and more in males, less in females. But in my particular experiences, it is very much higher. And like in city where I practice, Mumbai, almost I feel that almost more than 25%, almost 30% of the general population has some form of GERD. It may be mild, and most of these patients, they don't even consult their family physicians, or they don't even consult a gastroenterologist. For them, the first point of contact is the local pharmacy shop, where they will go and they will always opt for some kind of either some tablet or maybe some PPI, and very commonly they also take a lot of antacids. Now, in the prevalence which you can see on my slides shows that Chennai has a highest prevalence of GERD. And the least possible, we can see is I think Pondicherry, where the only 5% of affected population has GRD. I don't know why there is so much of variation. Maybe the dietary habits, maybe the lifestyle does matter in these patients. Moving ahead. So, what are the main factors where GRD has to be plays a very important role? Of course, it's not life-threatening in most of the patients, but then it causes significant morbidity. Patients coming to us, they always complain that it leads to a lot of impairment in their quality of life. It leads to regular absenteeism at their workplace, and very rarely we see the complications like they have dysphagia, or sometimes they end up with some kind of Barrett's esophagus, or maybe very rarely with adenoCA, where the Barrett's was probably not picked up very early. So, as we know, the mainstay of the treatment of GERD is still on PPIs. After the 1970s, when PPIs were introduced, that has been the mainstay. The introduction of omeprazole and then subsequently all other molecules, they have been the mainstay. Now, even the patient who goes to the pharmacy store and asks for a acidity pill is very conveniently been given a PPI by the pharmacist, and then told them that this has to be taken for maybe then 5 days, 10 days. And inadvertently, or maybe because of ignorance, people tend to take PPI, especially PPIs combined with prokinetics like levosulfuride or maybe domperidone for prolonged time, which of course leads to a lot of complications. Patients very often come to me with a lot of side effects with PPI, especially with the prokinetics combined with PPI. And then we come to know that, okay, they have been self-medicating for a very long time. But as we all know, PPIs are overall plain, isolated PPIs are overall a safe drugs. And very rarely we have seen encountered side effects with PPI. In my opinion, what has happened is that PPI has been a common bystander in most of the treatment. Patient has pneumonia, he's being given PPI. Patient has liver cirrhosis, he's being given PPI. So in most of the diseases, in the most of the hospital admissions, a PPI is always included in the prescription. That is why, being a common bystander, it has been always involved in the controversies. And we actually don't know whether it is a PPI which is actually causing the side effects or whether it is something else. So, as we all know, some very rarely we have seen a decreased magnesium level, as rebound acid secretion after we discontinue them. Very B12 deficiency has been linked, and risk of other infection, especially like the diarrhea after on the prolonged usage of PPI. Similarly, when we shift to H2RAs and patients who are using long-standing PPI, sometimes they are not very well acclimatized to H2RA, and they always complain that PPIs were better. However, H2RAs we all know that H2RAs are safer in long-term usage as compared with PPI. However, their efficacy has been always under controversy because they are very mild acid suppressants. And drug interactions are known, tachyphylaxis, tolerance can occur after around 7 to 14 days of H2RA usage. And then alginates have been in the discussion for a very long time. There was only one manufacturer in India, which was an international manufacturer till 2020 almost. And I have been using alginates since 2010, and I've been a fan of it. But only one manufacturer was available all these 10 years. Subsequently, in 2020, there was a second manufacturer who came in India, and that revolutionized the alginates market in India. Now we have more than, I think, 10 people who are manufacturing alginates in Indian market. Alginates are naturally occurring from brown algae, seaweed. And these are basically the source of this algae, seaweed, is very important. Like they like particularly Abbott is manufacturing this from a place called as Dupont, Norway. And where they are known for very good quality seaweed. And it does matter when it comes for the quality. And this alginates, when they are combined with other components like sodium bicarbonate, calcium carbonate, they form a raft, which actually gives a very good result by coating the esophagus by this raft and formation of a physical barrier to prevent the esophageal reflux. As I said, the source is very important. So the quality of the alginates does matter in giving the efficacy of the drug. And only alginates with very low molecular weight and high gel strength are suitable for producing the effective reflux suppression products. So there were more, as I said, more than 10 products. There was one study conducted, and recently they found that one of the Indian product, which Digiraft, was supposed to be showing a better acid neutralizing capacity in the form of formation of the speed of the raft, the floating component of the floating characteristic of the raft, and coherence factor, which was found, and then the acid neutralizing capacity was found to be very good. Any raft containing preparations, we always see 2, 3, 4 points. That is a better acid neutralizing capacity, neutralizing profiles, strength of the raft, and the raft resilience compared with the low alginate content for formulations or those containing aluminum or magnesium based antacids. So benefits of alginates, of course, are unique mechanism of action as compared with other antacids. Alginate monotherapy is also now a preferred option for treatment with mild GERD symptoms. And alginates can be also used with PI to improve the symptoms, especially nocturnal acid reflux symptoms, or maybe people who are not very much responding to PPI therapy. And also in patients who have severe regurgitation or even the rumination syndrome like patients, I have got very good benefits from alginate containing preparations. Large controlled trials and a small uncontrolled studies and also our practical experiences, the patient opinion, efficacy of alginates for the treatment in the following conditions has been remarkable. Primary care in non-investigated patients, on-demand treatment, symptoms in patients with pregnancy and lactation, especially when patients are little reluctant to take acidity pills like PPI or H2RAs. And alginates can be a very good option as it is safe in pregnancy. And management of atypical GERD symptoms where patients have some mild dysphagia attributed to esophagitis. I have seen very nice comfort level for patients with mild esophagitis with alginate containing preparations. And of course, in children who are not very much willing to take pills, alginates can be a very good option. My wife is a pediatric gastroenterologist and she uses alginates regularly in the pediatric age group. And she's very happy with this, the efficacy of alginates as compared with any other antacids. So without wasting too much of time, let's begin with the today's discussion. And I hope it will be an interactive session where we will be able to discuss on few points and together make a consensus. Dr. Ishanu, you can proceed further with the first.
Yes, thank you, sir. So we will just change it because there are some issues with Dr. Aug'23. So we'll be starting with the nocturnal acid reflux. We have Dr. Gautam Manne who will be talking on nocturnal acid reflux. Then probably post that we'll come back to this topic. Dr. Gautam, are you there?
Yeah.
Yes. Sir, we can go ahead with your talk
just
now.
1 minute.
Yes. Sure, sir.
Good morning, everyone. Today, I'll be discussing about nocturnal esophageal reflux disease. Are my slides visible?
Yes, sir, it's visible.
Yeah, okay. So, what is the nocturnal gastroesophageal reflux? Actually, quite some time, patients, even without having any symptoms of a chest pain, are having trouble in sleeping. They are having a small breaks in the sleeping. So these people have been worked up and they were found to have a reflux disease. So it is very important to diagnose the nocturnal reflex, gastroesophageal reflex, and with the even patients without any symptoms related to the reflex also should be treated for reflex. So patients experiencing heartburn or regurgitation during the nighttime are said to have a nocturnal gastroesophageal reflux disease. And nocturnal GERD sufferers are more likely to have impaired sleep, decreased health quality of life, and significantly worse work productivity compared with the patients without reflux disease. Even though nocturnal reflex episodes are less frequent than the daytime episodes, they have been noted to result in more severe outcomes. And this may be secondary to the longer duration of reflex episodes with an increased contact time of esophageal mucosa with acid gastric contents. And the detrimental effect of acid on the esophageal mucosa may be further exacerbated by the diminished frequency of swallowing and salivary bicarbonate production during the sleep. The following studies have shown that almost 78 to 79% of the people are suffering from a nocturnal heartburn in patients with symptoms of GERD. In Loke et al. Reported that 47 to 34% of GERD patients had nocturnal heartburn and nocturnal acid regurgitation. And coming to the pathophysiology, it is during the sleep, the mechanisms that actually protect us from a reflux disease, they will be quite decrease in the efficacy of these protective mechanisms. Like in the patients, in the normal persons also, during the sleep, there will be a decreased salivary production, decreased primary peristalsis, and the tone of sphincter also might be decreased. So these things contribute to the increased chance of having a reflex disease. So because the protective mechanisms have decreased, when the patients have other comorbidities like obstructive sleep apnea and use in the sleep disturbances and other chronic comorbidities like asthma or cough, they tend to have a higher incidence of reflex disease. And other way also, the patients who are having GERD, they tend to develop other complications of GERD like dental caries and chronic asthma, chronic dry cough, and disturbances in the sleep. Because during the sleep, there is normally amnestic sleep disturbance. That is, the patient will not be aware of these disturbances. They have, in a few studies, they were noted that these amnestic sleep disturbances were very high in patients of GERD. And patient who aware, that is, patient who is having a disturbance in sleep and they are aware of it also, the number is pretty high in patients with GERD, nocturnal GERD. So what are the risk factors for these nocturnal reflex? That is insomnia, sleeplessness, daytime sleepiness, obesity, snoring, hypertension, asthma, and medications. So what are the symptoms of nocturnal reflex? They are similar to the normal GERD. That is, the patient is complaining of heartburn, regurgitation, bitter taste, chest pain, chronic dry cough, and asthma with dental erosions and sinusitis. So these are the complications during the reflex, and the patients who are having a nocturnal reflex tend to have more severity in the complications with erosive esophagitis and complications of reflex disease like peptic stricture and Barrett's esophagus and esophageal adenocarcinoma. How come we diagnose this GERD is, this is as per the new guidelines from American Journal of Gastroenterology, new consensus, patients who are suffering from heartburn, regurgitation without alarm symptoms can be tried with 8 weeks once before meal daily PPI trial. If the patient symptoms improve, then patient can be discontinued from the PPI. But if the symptoms recur or if the patient doesn't have improvement even in the primary treatment, patient need to increase the dose of PPI and go for endoscopy. So with the endoscopy, you need to characterize whether it is as a reflex disease, erosive reflex or non-erosive reflex, or any other complications are there or not. If we did not find any kind of erosive lesions or say features of reflex, we need to go for a reflex monitoring monitoring of therapy. So how will we manage nocturnal reflexes? First, we need to change the lifestyle of the patient by suggesting them to lose weight and just small changes in their life habits. That is, during the sleep, elevating the head of the bed and sleeping in the left lateral position and avoidance of a late night meals. Coming to the medication, medications used, proton pump inhibitors, antacids, alginates, and the histamine blockers, prokinetic agents, baclofen, and hypnotics. All these things, as per the new guidelines, PPIs are suggested once daily, but new guidelines, they, in case patient are not having a severe symptoms, are not suggesting to use PPIs during the night time. And antacids and alginates were more they are almost equal to the proton pump inhibitors in preventing the reflex disease. Proton and histamine receptor blockers, these are suggested to use when the PPAs are not effective, or if the patient, we can try with PPA, but not alone histamine blockers. In prokinetic agents, because they are having side effects, they were not suggested in the guidelines to be used unless patient is having any motility disorders. Baclofen, only when the patient is having a significant symptoms and also evidence-based. That is, the patient is having endoscopic findings, only then it is suggested to use baclofen as per new guidelines. Hypnotics. Why should we use hypnotics is the cause of severe reflexes and sleep disturbances in the nocturnal reflex is the patient, they are having a hypersensitivity whenever the patient is having a breaks in the sleep or is deprived of the sleep. So because of that, the hypersensitivity increases, and even for a non-acid reflex also, patients tend to get up. So to prevent this and to have a continuous sleep, it is as per new guidelines, it was mentioned to continue to use hypnotics. Patients who are not having improvement with the medications are advised to go for surgery. So, ACG describes bedtime use of PPS in case of nocturnal GERD. So what does your experience say?
We can have this as a discussion. So yes, sir, Dr. Gautam, you can start with your opinion. I think then we can have a opinion from the chairperson,
Okay.
and we can involve the rest of the panelists on this topic.
Okay. So as per my experience, PPS actually have a very good decrease in symptoms when used in a double dose, that is BD dose. But because of our long-term use of PPA were associated with the complications, but not many were proved, but few associations were noted. To avoid these complications, it's better I have started using alginates also during the night times. So for me, it actually worked, and I was able to decrease the PPA doses also during the night times. Can anyone discuss about their experience?
So let me add.
Yeah.
So, Dr. Bane, what have noticed is that some patients we need to just go behind and take the history properly. If the patient says that patient is having only complaints during the nocturnal time, not in the daytime. So see, anyways, we give once a day PPI is our recommendation. So if we can shift a morning dose of PPI in the evening before dinner, and that suffices quite well, then I'm happy. The patient is doing well with the once a dose, once a daily dosing PPI, maybe before dinner. But some patients might not feel better with that, and they might complain that they still have nocturnal acid breakthrough. So such patients, I then add alginates along with the PPI at the bedtime. Maybe sometimes start with the 10 ml dose once at bedtime with alginates, and then subsequently also suggest them that you can take 20 ml at bedtime and look for the response. They are doing good, then maybe I subsequently I taper up the dose of PPI from, maybe if it is a esomeprazole 40 milligrams, I shift them over to 20 milligrams of esomeprazole, or maybe a pantoprazole from 40 to 20, and then subsequently withdraw the PPI and just ask them to continue alginates on SOS basis when they have optional acid refluxes. Otherwise, on the long term, I plan to stop all of them and keep just alginates as SOS basis during the bedtime. So how is the experience with other panelists?
I agree with you, Dr. Vedant. I absolutely, I think I'm doing the same practice as you were mentioning. Most of the time, yeah, we will try and shift the PPI to the night and replace it with alginates as much as possible.
Correct. That's a good strategy, I feel. And of course, I discourage prolonged use of PPI on at least for the high dose PPI. Maybe low dose of PPI if the patient is doing good. We should also then, of course, as Dr. Mane just discussed, we should do an upper GI endoscopy, see whether there is any underlying problem like reflux esophagitis or maybe an H. pylori infection or an hiatus hernia, which is contributing to their nocturnal acid reflux symptoms. If everything is normal, it is a non-erosive reflux disease, then I think we should also evaluate whether the patient has a functional overlay or not. If, as Dr. Mane discussed, maybe the last point, use of hypnotics will sometimes help these patients, because as such there is it is only the functional GERD, and adding hypnotics in a low dose can actually help these patients to get off with PPI and also get off with alginates in long term.
Most of the time, we see them dependent on PPIs more than the actual necessity. They feel better only when they take PPI.
Yeah, exactly. Because mainly the patient's psychology that PPI is very convenient, and then they feel little better with PPI. Maybe 5 or 10% symptoms also, then they are ready to gulp it on long term. Right. Second question: do you recommend twice daily PPI for nocturnal acidity? As we already discussed that. Do you prefer any alternatives to PPI in managing the nocturnal? We have already discussed all three of them.
Yeah.
Yes.
So we have Dr. Amit, also Dr. Swapnil and Dr. Darshil, and among the others. We could take opinion on this topic from any one of the doctors, and we can move on to the next part of the Dr. Amit, if you could, any opinions, are you aligned with the opinions of the doctors, or is there any suggestion from your side? So I think we'll move on with, because of the time constraint, we'll move on to the next
Yes.
topic.
Yes.
Dr. Gautam.
So these are the studies which have compared alginates with the placebo and alginates with the omeprazole. But we can actually see that when comparing with the placebo, alginates were significantly better in relieving the symptoms and the endoscopic changes also. In Chiu et al., it was done in 2013, which is a randomized study. They are compared with omeprazole, and the results were actually comparable when using alone or when using combined with PAs. So what is actually a nocturnal acid breakthrough is, even with the use of a PPIs, when the patient is having a drop in the intragastric pH less than 4 for an overnight period of at least 60 continuous minutes in patients on PPI, is defined as a nocturnal acid breakthrough. So patient even having even on PPIs twice daily, they are having this phenomenon in 80% of the patients. So this nocturnal breakthrough actually happens during the first 3 hours. They have actually mentioned in the first 1 hour, and in the recent studies they have shown that even with use of PPIs, the most important thing is the first 2 to 3 hours. If the patient has consumed food and had lied down or went into sleep, the first 3 hours have been the most important, because the acid output and also the pH have been drastically reduced, and the number of reflex episodes have been greatly increased. So what they have done is they have studied when the patients who are taking PPI alone and PPI with alginates, the number of reflex episodes and the complete symptom resolution in the form of 28 heartburn days have been significantly much better in patients who are having a PPI with alginates rather than using a PPI alone. So summarizing, there's a nocturnal GERD sufferers mostly have a heartburn during the sleep and sleep disturbances, and the complications of a nocturnal GERD are much more in patients who are experiencing nocturnal GERD rather than in patients only who are having GERD during the daytime. Several clinical trials showed that alginates have reduced regurgitation more effectively than placebo and antacids. And the recent evidence showed that sodium alginate along with PPI provided complete symptom resolution in patients with a nocturnal reflex. So, as discussed earlier on how alginates are not the same, so do you believe that alginates with a stronger raft and more resilient raft will help in this particular profile of patients with a nocturnal GERD? What other properties of alginate formulation would you consider before choosing one for patient of a nocturnal GERD? This, as per like my short experience, I have actually used different brands and tested a few brands which have a stronger raft. They have a significant improvement in the symptoms, and I don't find any issues in those patients. So, panelists, can you discuss what your experience is?
Sir, I would request all the panelists just to contribute here and also to switch on the camera so that everybody could have a discussion on this. Which Dr. Amit, your opinion on this?
So mine is same thing that I have tested other brands also. Though the raft quality is more with Digiraft we have seen, so its longevity with the Digiraft is more. But other raft also will work for 2-3 hours, not a big issue. So I think whatever alternate preparations they are good. It should be allowed with other PPIs.
Vedant, sir, you want to add anything on this?
Most of the alginates are doing good, as Amit suggested. But yeah, there are some differences where the alginate nowadays we have a higher alginate containing preparations available in the market, and this higher alginate containing preparations are said to be better. Although my personal experience is little limited on this, I have not tried them much. Then yes, they suggest that when you take a higher alginate containing preparation, duration of the action is better, and the nocturnal acid refluxes can be better managed. I think we'll need more practical experience because it has been recently introduced in the market. So the experience is limited for the time being. I think maybe in next like 6 months to 1 year, I think we'll have a better practical experiences on the double dose alginate containing preparations.
Thank you, sir. Dr. Siddharth, Dr. Darshil, so you want to add anything, sir? We'll move on to the next part because it's around 11:45 and we still have three more topics to be discussed. Thank you, Dr. Gautam, for talking on nocturnal acid reflux and sharing your opinion. I think we'll have a poll question, anonymous poll question of why right now. Then post that we'll be moving on to the next topic. Melroy, can we have this poll? What is the first line pharmacological treatment for acid reflux in Melroy? We can close the poll.
Should go to the next poll.
Yes, we'll move on to the next one. The most important physicochemical property of an alginate antacid formulation. We can close the poll open. We'll keep 30 seconds as a time limit so that we can tick on to our agenda. On to the next one. Do you believe that all alginate formulations are the same? We'll close the poll for this question. For the next question, please. most effective property, physicochemical property of an alginate antacid formulation, mostly useful in a patient suffering from postprandial acid reflux. We are looking at a specific patient profile of postprandial acid reflux here. We can close the poll now. On to the last question before we move on to the next topic of discussion. You believe that a higher calcium carbonate content would be beneficial in an alginate antacid combination? We can close the poll. Milroy. We will be moving on to the next topic of discussion in today's focus group discussion. We have Dr. Alok Kumar Mantri sir, who was the speaker on the postprandial acid reflux. But due to some issues, he's not able to join us now. So I'll be going through the slide deck for this discussion. I'll be just present and we can have an open discussion on this topic. I request all the doctors to contribute to this during the session. Okay, we'll be just moving into the topic, the second topic of today's agenda, that is a postprandial acid reflux. So coming to a brief overview or an introduction into the topic, postprandial acid reflux is a feature usually it's a common feature usually seen in GERD, where the gastric content reflux into the esophagus, which leads to the typical symptoms which are seen in GERD. GERD is known to affect the health and impairs the quality of life in a significant proportion of population worldwide. And as Dr. Vedant was also saying, there's almost 50 to 60% of the patients who report daily are GERD patients. And according to the data of a pooled prevalence study, almost the GERD symptoms are seen in at least 13% of the patients weekly. Coming to the mechanism of postprandial acid reflux. So the main the concept postprandial acid reflux came into the picture because when the investigations revealed that when the intragastric pH after a meal increase, that is from pH 1.4 to 4.4, but it remained highly acidic, 1.6 in the region adjacent to the esophagogastric junction and the fundus of the stomach. The normal ideology is that once there is food, it is going to neutralize the acid within the stomach. But even then, the pH was still on the lower side. That is, pH was around 1.6, even though food was taken. The difference between the gastric pH and the reflux rate pH after meal led to the discovery of this concept of acid pocket, which was earlier not usually discussed. So acid pocket basically is an area of unbuffered, highly acidic gastric secretion that accumulates postprandially in the proximal stomach, mainly near the esophagogastric junction and the fundus. So coming to the mechanism of postprandial acid reflux, the most acid reflux events and symptoms episodes occur after meal. However, ideally in this period, intragastric contents are at their least acidic stage due to the buffering effect of food. That is what the earlier mechanism was. but this postprandial pocket of acidity can persist for up to 2 hours after meal. So, which acts as a reservoir for the acidic gastroesophageal reflux, which occurs in both healthy individuals and also GERD patients. Just to mention studies where a pH monitoring tracing of a postprandial gastric acid pocket or postprandial acid reflux was done, which showed that through the pull-through pH monitoring, there was a lower pH which was observed. As you can see in the picture, even though in the postprandial stage, the pH is on the lower side, that is around 1.6. Coming to the typical symptoms, basically, we are looking at typical, atypical, and also the extraesophageal symptoms which we commonly see. The most common or typical symptom is seen is regurgitation or with regurgitation and heartburn. And coming to the atypical symptoms, which mainly includes an epigastric fullness, epigastric pressure, epigastric pain, dyspepsia, nausea, bloating, belching, where there is more of an overlap of GERD with a functional dyspepsia. And the third part is extraesophageal symptoms, where it is mainly characterized by chronic cough, bronchospasm, wheezing, hoarseness, sore throat, asthma, laryngitis, and dental erosion. These are mainly where a LPR or a laryngopharyngeal reflux is most commonly seen. Coming to the diagnosis, so this is based on ACG guideline, which says that if the patient has sore water, regurgitation, or heartburn, with or without any alarm symptoms, usually 8 weeks once before daily PPI trial is done. So this is leads to a GERD diagnosis. If there is complete relief, then there is GERD is likely, or else discontinue PPI. If the symptoms occur, then we go for an endoscopy. So I would just like to stop here and take the opinion of the panelists here. So how frequently is an 8-week once daily PPI daily meal is being practiced in clinical practice, so that for the diagnosis of GERD?
Let
Can
me
you
add.
repeat the question, please?
So guidelines mentions that an 8-week once daily PPI trial is necessary for the diagnosis of GERD. In clinical practice, how frequently is this done? Is an 8-week trial done? Is it a once daily PPI, or as the earlier discussion was also there, is a double dose PPI? So how is a diagnosis, or it's an empirical treatment? How is it done in clinical practice?
It's very difficult to do for 8 weeks to continue to have same medicine, because patient rarely come after 8 weeks. So I don't think my practice is at least 4 weeks we give the trial. If the response is there, then we go for endoscopy response.
Sir, I also wanted to know, because right now PPIs are usually over the counter, most of the patients take it. So how frequently PPI naive patients come to you for when they have GERD? Will it make a difference in diagnosis or anything?
Definitely. It's unlikely we get, because we are at the tertiary center.
Yes, sir.
So whatever patients are coming, they are mostly some referred by some GPs, or most have gone to their local physician first. They have tried multiple types of PPI with various combinations. So very rare to get a naive patient for to start a PPI.
Okay. So I would also like to know the opinion of other panelists here.
I would say one thing here.
Yes.
See, basically, ACG guidelines are for America only. In India, definitely the first day the patient comes to you, they come to you with an intention to get an endoscopy. And
True.
it is the best thing to go and do an endoscopy in all these patients. Definitely, they must have used over the counter. They must have been prescribed by multiple other GPs. All PPIs, they must have finished already by the time they come to us. And in spite of that, if they are having symptoms, definitely going for an endoscopy is the best thing to do, is my opinion.
Definitely true, sir.
Just Is it endoscopy like once they on the very first visit, or even an PPI trial is done? I just wanted to confirm.
Based on the symptoms. Basically, if someone is coming to you without using a PPI, yeah, we definitely can give a trial of PPI. We definitely offer the patient about the trial of PPI. But if already they must have used, they tried for 2 or 3 months already, then the best thing is to go for an endoscopy. And more so in patients who are little elder people, more than 50, definitely I don't think we should wait for an endoscopy to be done. Endoscopy is cheap, easier in India. I don't think we should compare the guidelines in US. They will have a lot of protocols for someone to go for an endoscopy. But here endoscopy is very, very cheap procedure than using PPI for the 8 weeks. Endoscopy is cheaper actually.
Okay, sir.
I think your guideline should be separate for India.
Okay, I think we need to, Indian guidelines should be modified as per the separate population.
Yeah.
Dr. Vedant.
Yeah, I agree with the consensus. Basically, patients are impatient. They cannot wait for 8 weeks. Even most of the patients, as Dr. Amit said, they have already taken PPI for around a week or 10 days, and they're already impatient by the time they visit you. They will upfront tell you that I have been eating this PPI or the pills or maybe antacids for already around a week's time, and there is no relief. So rather than waiting, you can directly counsel them that okay, we can go ahead for a upper GI endoscopy and get the diagnosis clarified. In case if they are apprehensive about the endoscopy, then I wait. Or maybe patients who are very much concerned about an H. pylori, I explain them, okay, we can do an urea blood test for an H. pylori, get whether the H. pylori is positive or not. That can be ascertained. But if it is negative, I immediately I insist for an upper GI endoscopy.
Thank you, sir. Sir, how frequently is H. pylori done? Just wanted to know because for diagnosis.
We frequently do H. pylori in all patients with GERD, and roughly around 20% patients we get positive.
Dr. Siddharth, would like to know your opinion.
I want to ask the other panelist. Sometimes the H. pylori does change its color after 24 hours. Is there any significance?
No, most of the time, my mentor, Dr. Shobna Bhatia, she has done extensive work on this H. pylori, especially the RUT-based kits, and she very clearly says that you have to observe it only up to 30 minutes. So if it is, we are waiting for maybe 24 hours, and the other contaminants, the other bacteria in the gastric lining can also cause a false positive H. pylori RUT kits. Where the previous kits where nowadays I think most of us are using the RUT dry kits, and earlier we were using the kits where used to put the wet kind of kits which had a big deep well inside, and those type of kits I think they used to recommend a very longer duration. But in I think nowadays it is only 30 minutes where we see, and we immediately declare the results of the H. pylori within 30 minutes of an upper GI endoscopy. And they also instruct the patient that if it turns red on the next day, don't you can ignore it safely because it clears the confusion amongst the patient.
So one more question, and in your clinical practice, what is the compliance that you see with the HP kit, sir? The amoxicillin clarithromycin. How well do they tolerate the kit, and how much, like, what percentage of patients do you think they complete the treatment? Since you're into the practice for a really long time.
So that is an excellent question, Dr. Siddharth, and we were actually expecting this question for a discussion amongst the panelists. So in Mumbai particularly, the Mumbai Gastroenterology Society, we always had a discussion on this, and most of the gastroenterologists are of the opinion that clarithromycin resistance particularly is very, very high in our area, Mumbai area, and that is why most of the gastroenterologists will avoid using clarithromycin. If you see most of the prescriptions from medical gastroenterologist in Mumbai, you will see that they are avoiding clarithromycin except for few. And the reason is the high amount of resistance. So most of these patients, when we follow up by an urea blood test or something, they turned out to be positive after the clarithromycin course. So what our practice is that we have already shifted to quinolones like levofloxacin along with amoxicillin. And along with that amoxicillin, of course, it has to be 1 gram twice daily rather than the HP kits which provide 750 mg twice daily. And apart from that, we add another imidazole derivative like tinidazole, or nowadays we are also using nitazoxanide, nisonide. And so 3 drugs, 3 antibiotics, and PPI.
What about
So that is
compliance, sir?
compliance. Yes, we have to counsel them. We add sometimes bismuth also to these patients, and we counsel them that the drugs are notorious and they can create a lot of disturbances. Another thing very important is that we have been always taught in our UGPG days and also during the gastroenterology training days that if there is no ulcer, active ulcer, or severe erosive gastritis, so you should not emphasize too much on treating for H. pylori. That has been a very important part of a discussion. Even few of the gastroenterologists, they don't bother even if the H. pylori is positive and the gastritis is very, very minimal. So I'd like to know your all of yours take on that. Whether you guys routinely treat the H. pylori if you see a very, very mild gastritis or maybe a apparently normal looking upper GI endoscopy, and if you get an H. pylori positive in RUT, will you go ahead and treat it or will you like to ignore it?
My take on this, sir. I was actually trying to talk about this only just now. You said you are seeing only 20% of your patients with RUT positive. So for any patient with dyspepsia, if we are doing an endoscopy, we are seeing around 80% positive H. pylori RUT positive.
Oh,
80% I mean, I've been practicing in Hyderabad for the last 10 years, and I was in Bangalore for 2 years.
okay.
And in Hyderabad, especially, I'm seeing at least 80% of patients present to us with dyspepsia. It can be, I mean, clinically, there can be ulcers on endoscopy, there can be minor erosions, or there can be severe gastritis. But we are seeing at least 80% positive, sir. And I tend to treat each and every person who comes with the RUT positive. And as you said, clarithromycin resistance, we are actually seeing in at least 20 to 25% of patients here. So in those patients, I mean, we have a lot of different kinds of patients here. People who are residing in Hyderabad, definitely we are not giving clarithromycin. People who come from outside, we have patients from Nanded, we have patients from African countries, from Andhra. There we are, those people we are giving clarithromycin combination.
Yeah,
And
that is a good
maybe
practice actually.
differentiating the people who from the place they are coming. And we are treating everybody, sir. We are treating everybody for H. pylori. And after treating H. pylori, then only I am differentiating whether it is functional or not functional. Many of my patients who are thought to be functional dyspepsia are doing very well after treating with H. pylori.
You're correct. You're actually, when I have a similar experience where functional GRD thought initially, and after the treatment of H. pylori, they became totally, the functional overlay totally disappears.
Exactly, sir. So we have
So
to
you,
label them functional only after treating H. pylori.
correct. And what I wanted to know, Dr. Siddharth, is that are you a sound checker, doctor? You are reporting the RUT positive after half an hour, or is it after 24 hours?
No, sir, only half an hour. Half an hour, maximum 45 minutes, sir. After that, we don't take it as positive.
Exactly. So then I'm quite surprised with that 80% is positive.
Yeah,
Because,
we are seeing a lot
have,
of patients, sir. So
we
I
tried
made
to
it.
bring the
I've
kids.
made it mandatory that every endoscopy with dyspepsia they should be doing an RUT.
Right. Well, that is better good practice because lot of times we see even with the normal patients with the normal mucosa, the H. pylori turns out to be positive, but they have significant symptoms. And
Symptoms, yes.
when we try to treat such patients also based on their symptoms with the H. pylori treatment, I've seen that they improve. They improve drastically, and then their complaints also improve quite significantly. The functional overlay also reduces if you successfully treat the H. pylori infection.
Yes, sir. We are actually treating almost, I mean, 80% is like a huge number. But because we are seeing more, we are doing the test for everyone now.
Okay.
There
Sir,
was
one
a
more
study.
query. Dr. Somshekhar Rao, sir,
Yeah.
wanted to ask you, is there any particular site do you prefer on taking the sample from? It is said that people who
We
are
we
on
generally
long-term PPI.
we generally tend to do it above the incisura, sir. Above the incisura. I don't take biopsies
Correct.
from the antrum at all.
So in the fundus and body, sir.
Yes, body.
Body, correct. Above the incisura
Preferably
is the
body.
common site from where we take. We normally obtain two bites, one from the above the incisura and one from the area which shows the maximum amount of erosions.
Erosion. Yeah.
Two
So the
samples.
trend what we see is most of the time people who have been on PPIs for prolonged period of time, the erosions and all will be more in the body and the fundus. Antrum will be clean. You don't see any gastritis in the antrum when they are on long-term PPI.
So can we move on to the next topic? I think this discussion we can have it
Yes.
at the end of
Good
this.
question.
Yes.
Sure.
So just I'll just highlight the management with postprandial acid reflux. We have PPIs, we have H2RA, RA, that is histamine receptor antagonist, we have alginates and antacids and PCAPs are the new class which is right now available for management of GERD. So just want there the Southeast Asian guidelines recently in 2021 came up with a consensus statement saying that in treatment of mild to moderate GERD, alginate stands as a first line of treatment. Even if symptoms persist, even after alginate treatment, then PPIs are used and combination therapy with PPIs and alginates is partially responsive to PPIs. We just wanted to know on this opinion from the doctors that how frequently is alginates used as a first line for treatment of mild to moderate GERD in your clinical practice? Because there's a Southeast Asian guidelines, can alginates replace PPI because PPIs are the first line for mild to moderate GERD? Can alginates be the first line treatment? Dr. Darshil, can Dr. Somsekhar?
Younger patients with mild symptoms, definitely I would say yes.
Okay.
That can be the first line of treatment.
Asa, any reason why not in older patients?
Older patients, they may be having symptoms for prolonged period of time, and if you do an endoscopy, they may have some esophagitis already. So for at least initially till the esophagitis comes down, maybe PPI would be required in them.
Okay.
But younger patients, you may not see erosions and all. Very rarely we see erosions or severity. And with mild symptoms, when you're saying, I would say, yeah, maybe we can use this as a first line medication.
Okay, sir. So anybody else like to add on this? Dr. Gautam?
Sir, I would agree with Shomshekar, sir, because if the acid output is really high and if we don't start PPS in those kind of patients, it will be disastrous for them. So as of now, we are treating with alginates along with PPS, even for patients with moderate GERD.
Okay, thank you, sir. Dr. Vedant, would you like to add something before we move on to the next slide?
I agree with Dr. Somshekhar sir and Dr. Gautam.
Oh, thank you, sir. This is again a point of for discussion. Do you believe that postprandial unbuffered reservoir of acid, that is acid pocket, is present even in the patients on PPI? And for diagnosis of GERD, do you prescribe PPI once or twice daily? And the third question has been already discussed, that is a first line management in mild to moderate GERD. And what is your opinion on new class of drugs, PCAP? I'd like to know the opinion of all the panelists on this. We can start with Dr. Siddharth here. Dr. Siddharth, are you there?
Yes. I do definitely patients who are on PPIs, including myself. I have experienced reflux symptoms. So PPI alone may not be good enough for the management of reflux symptoms. At least for that immediate relief of symptoms I'm talking about.
Okay, sir. Sir, also, they wanted to know how do you prescribe PPIs once or twice daily? And if it's twice daily, can it be replaced with a once daily PPI along with an algidate? Can that be also tried because PPI alone, you said, does not control the reflex? Dr. Somsekhar?
My take on this, most of the time, double dose PPIs we use during that 14 days when we give H. pylori eradication, and then most of the time it is single dose PPI. But if at all someone is requiring a PPI double dose, maybe definitely we can replace it with alginate. I am a strong supporter of alginate because of its less side effects and efficacy.
Thank you, sir.
Just something I want to ask. This PPI is single dose or double dose. Do you use it just PPIs or do you use PPIs with a prokinetic? Just addition of prokinetic to a PPI, does it actually make a difference in your set of patients?
So
Patient with
prokinetic, I don't think there is any role along with PPI. It's just satisfaction, except in patients with gastroparesis. Specifically, we know that this patient has gastroparesis. Otherwise, I don't think in just GERD, treating GERD, there is any role for prokinetics. This is my take. Vedant, sir, your opinion, please.
So prokinetics we use only for patients who have a severe reflux or they have occasional vomiting episodes. And then such patients, even I have tried in patients who giving them a standalone prokinetic in the evening time, who have especially nocturnal acid refluxes, and along with alginates. I have tried to avoid PPI also, and tried to see what is the experience. So these patients do little bit better as compared with only isolated alginates, rather when we add some prokinetics. But then it is in the few subgroups only. And then again, the prokinetics, we cannot give for a longer time. We need to slowly taper off. I start with the sustained acting prokinetics, like etopride, maybe 150 milligrams, and then subsequently I start tapering them off to maybe 50, around 100, and then 50 milligrams, and then I slowly stop it. So little bit of benefits in selected group of patients, not in all.
Agreed, sir. I agree. Definitely. People who have postprandial distress, people who have gastroparesis of any other cause, definitely
Exactly.
prokinetics have a role, but not as a combination for everybody.
Yeah.
And maybe shortly all these combination drugs will be banned in India.
That should be good actually, because people are taking levosulfuride combined with this PPI for a very long duration, especially from the other specialties when they come from the orthopedicians or physicians or maybe general practitioners. They have been and they are very badly addicted to levosulfuride. And then by the time they come to me, they already have the neurological effects, or maybe females coming with the hyperprolactinemia. and then we just have to stop it, and then all the symptoms goes off in a couple of weeks.
Agree. So we'll move on to the role of alginates in postprandial acid reflux. Just want to highlight few of the pharmacological profile of alginates here. So this is why we want to reiterate that all alginates are different. The chemical composition and the physical properties of alginates from where it is obtained based on its source determines the characteristics of the alginate. Only certain alginates have this effective reflux suppressant activity. So the three main active ingredients of alginate preparations are sodium alginate, sodium bicarbonate, and calcium carbonate. So when this combination of sodium alginate, sodium bicarbonate, and calcium carbonate come in contact with an acidic gastric environment, they form a strong, voluminous, buoyant raft. This raft suppresses the reflux and relieves the symptoms of the heartburn or GERD. So mechanism of action of alginates mainly have this unique non-systemic hit because it's an inert substance. There is no systemic absorption. Thereby, it forms a physical barrier and it has a physical mode of action. So the selection of alginates or the correct alginate is essential for a better performance, which has to be seen. Coming to the mechanism of alginate again, in the presence of gastric acid, alginate precipitates to form an insoluble alginic acid gel. This alginic, along with the bicarbonate which is present, which converts it to the carbon dioxide. Carbon dioxide form gets entrapped within the alginate gel matrix which is being formed. It gives the buoyancy to float over the gastric contents that is on the top, which leads to formation of the raft. Coming to again the mechanism of action again, once in the presence of gastric acid, the gel produced by the alginate forms a physical barrier and thereby it prevents the esophageal mucosa from having any erosions or any inflammation. Again, in prevention of postprandial acid reflux, because postprandial the near the gastroesophageal junction, the pH is low. This raft forms as a cap on the acid pocket, and thereby it prevents or reduces the postprandial acid reflux again. So even though with just PPIs, only the acid secretion is avoided because even though the gastric secretions also has pepsin and bile acid. So this raft prevents the pepsin and bile acid also from entering into the esophagus, thereby just preventing the enzymatic activity of pepsin on the esophagus. And it also plays a major role in topical protection of the esophageal mucosa and prevents the risk of inflammation. So these are the major modes of prevention of action of alginates. Just want to talk on the calcium content. What is the role of calcium in the strength of the raft? So calcium mainly increases the raft strength. So these calcium ions being studied in vitro increase the raft strength, whereas aluminum, which is present in most of the antacids and the raft, is going to reduce the strength of the raft. So mainly, it is the ability of the calcium to cross-link the alginic acid polymers, which helps in forming an egg box structure, which provides a great strength or provides the resilience to the raft formation of the strong raft. Just to reiterate here on the same thing, the increased calcium content helps in formation of an egg box structure, which is seen here. This provides, which makes the raft sturdy and it makes it a strong and resilient raft. What is the role of alginates in the management of postprandial acid reflux? Again, there was a study done to locate the alginate in relation to the acid pocket. This was mainly done to visualize the position of the alginate raft after administration of sodium alginate, bicarbonate, or calcium carbonate in GERD patients, and simultaneously the effect of the reflux parameters were considered. Mainly, it was a labeled study where alginate was mixed with the radio label study. So here, as you can see in this picture, there is a relative localization. This is, as you can see, the acid pocket can be seen in this tree. And post later, once the alginate is given, it mainly acts on the, in the third C picture, you can see the alginate mainly acts on the acid pocket and it prevents the reflux from going up. This study showed that the raft actually acts on the acid pocket and prevents the reflux rate of the acid going into the esophagus. Thus, coming to the data again, the 71% of the patients who received alginate antacid had an acid pocket below the diaphragm compared to 21% of the patients who received antacid. So it keeps the acid pocket in check and prevents the reflux of the content. Similarly, there was one more study which was done where it alginate antacid formation on the postprandial acid pocket again, where they analyze the ability of alginate antacid to neutralize or displace the acid pocket in GERD. Here, 10 patients with symptomatic GERD were studied in 3 conditions, mainly in fasting conditions, 20 minutes after consuming a meal, and 20 minutes of an oral dose of alginate oral antacid formulation. Here, as you can see, the looking at the pH here again. So where most patients exhibited an acidified segment extending into the proximal stomach. This picture mainly showed the effect of antacid, where how low the acid pocket was with an alginate antacid combination. The acid pocket was into the stomach or below the distal esophageogastric junction, whereas the fasting condition and the postprandial, the acid content was actually at the median esophageal gastric junction. So coming to the key takeaways here, that is postprandial acid reflux is a characteristic feature of GERD, and most acid reflux events and symptoms occur after meal. However, ideally in this period, intragastric contents are at their least acidic due to the effect of buffering action of food. So alginates are medications that work through an alternative mechanism, that is, it displaces a postprandial acid pocket. And these acid reflux events and symptom episodes, which usually occur after meal, can be prevented using alginates here. So that was just a brief idea of alginates on it. So I think which comes up to the point of discussion for us here is, in which type of patient profile, or do you choose to use alginate antacids alone, and when do you choose to use them PPI? I think it can be an open discussion here, because this is really on a clinical practice perspective. When is the combination is used, and when is along with the PPI? Dr. Gautam, can we start with you? Dr. Vidan?
Yeah, I will use alginate antacids alone in patients who are having very mild symptoms.
Okay.
And, yeah. And with the PPI, the patient is having a significant or moderate to significant complaints with the reflex symptoms. I would rather go with the PPI combination along with alginate and antacids.
Okay. Dr. Amit? Dr. Amit, your opinion on this? When is antacid alone, alginate antacid alone, and when do you give the PPI? Dr. Vedan?
Yeah, I agree with Dr. Gautam. It's
Yes.
whether we have to totally be dependent on the symptoms of the patients. If it is a very mild one and the patients require SOS medications, once the upper GI endoscopy has been done and you have seen there is no H. pylori, no hiatus hernia, and patients develop this intermittent mild symptoms, then maybe you can tell them just to take standalone alginate preparations as and when required, or maybe as they have a nocturnal acid reflux, and maybe just at once at bedtime. That is when the only alginate preparations come into the role. But these are also the patients who require intermittent use of PPI, whenever they have too much of symptoms. And PPI also, they need to be intermittently add PPI into such patients, especially when their lifestyle goes for a toss, and they might require PPI along with alginates.
Dr. Somshekhar and Dr. Siddharth, you want to add anything on this?
I agree with Dr. Vedant and Dr. Gautam.
The next question is, will higher calcium carbonate in alginates help with better management of hyperacidity with acid reflux?
So, Dr. Ishanu, I wanted
Yes.
to ask you here whether are there any preparations available in the market which have particularly high calcium carbonate in
Yes,
alginate? Because
Yes,
I am not aware about the high calcium carbonate content.
Yes, sir.
I think.
Oh, yes, sir. There is higher calcium carbonate with us also. As I mentioned, there is going ahead with there is where the calcium carbonate with an earlier plain alginate was mainly for 10 ml contained 160, whereas the that was a plane which was launched earlier. That was the first one. And as I mentioned, which we had launched it this year also, the newer one has almost 325 mg of calcium carbonate there.
Okay.
It's a higher calcium carbonate, which is mainly looking at neutralizing the acid.
So this is a new one which you have introduced recently.
Yes. Yes.
So the experience is limited, as I said, because it's been only, I think, couple of months that you have launched.
Yes. So it's mainly to reduce the antacid, more happen antacid action also, along with an alginate action. It reduces the hyperacidity which is seen.
One more question I had, Dr. Ishanu, with
Yes,
you
yes.
from respect to the manufacturing line, whether this calcium carbonate increase in the calcium carbonate content, is there any other adverse event or something that we are looking forward? Which should be avoided in particular group of patients?
Sir, as of now, we have the data available doesn't show any side effects along with it because it's more this absorb because it's inert action, and once the carbon dioxide is released, it is is stuck in the gel. There is no side effect seen, and because within 4 hours, once the study the alginate, because it is excreted normally directly. So there is no much systemic absorption.
It is not absorbed.
Yes, the systemic absorption is very, very less, so the side effect profile is also very not noted. And no any side effects observed till now. Sir.
We move to the next question.
Yes, sir. Which physicochemical property of alginate was considered for patients suffering from postprandial reflux? What would be?
We discussed about the high alginate contents and the high calcium carbonate contents.
Yes, sir.
That will definitely help us to see whether how much is it better scoring as compared with your previous product. So then accordingly, maybe after maybe 6 months to 1 year, we'll be able to have a personal experience on it after using this. Patients who were earlier on the regular alginates and maybe on the high dose of alginates with calcium carbonate, we will be probably getting a personal experience after some time.
Thank you, sir. Sir, I think we'll be moving on to the next topic.
Yeah, I think we are in constraints of time. It's already 12:35.
Sir. We have Dr. Somshekhar sir, who will be talking on refractory GERD. Sir, should I share your slide on? Sir, you are on mute.
Please, Ishanu, please share my slides.
1 second, sir.
I think I will make it quick. We have discussed a lot of things already.
Yes, sir. Just confirm if you are able to see the slide.
Yeah. So we are talking about refractory GERD even in patients who are on PPIs. So the topics are persistent gastroesophageal reflux disease. I will be talking about the reduction disease burden and causes, management of the patient with incomplete response to PPI therapy, and how our alginate-based therapy is going to help us. Introduction to refractory GERD. When do we call it as refractory GERD? The first line of treatment for GERD involves acid suppressive therapy and proton pump inhibitors. Although PPAs have a high success rate, 30% of patients still experience symptoms associated with GERD. And further evaluation may be needed if the patient does not respond to PPAs or exhibits alarming symptoms like abdominal pain, dysphagia, odynophagia, vomiting, and weight loss. So this is the question for everyone here. How frequently do you see patients with refractory GERD? My take, I agree with that 30%, definitely. I mean, when I'm talking about refractory GERD, they are not responding to a single dose PPA. This is when I call them refractory. And my experience, I would say maybe around 25 to 30%, yes. Others take on this, and at least percentage of patients whom you feel doesn't respond to single dose PPA.
I read with Dr. Somsekhar, sir.
With sir, around 20 to 30% of patients who come to us do have they do not respond to single dose PPI.
Can we go to the next slide, please? So the burden of GERD from 2005 to 2010, Southeast Asia's prevalence of symptoms-based GERD was estimated to be 6.3 to 18.3. Primarily, it was thought to be a Western disease affecting 10 to 20% of population in North America, Western Europe. Now, because of the dietary changes and increasing obesity and the type of work what we do, the prevalence has increased in our country and whole of Asia also. So what are the causes of GERD? Poor adherence and compliance, esophageal hypersensitivity, irritable bowel syndrome, weakly acidic or non-acidic reflux, residual acid, delayed gastric emptying, and rapid PPA metabolism. There can be some causes which may be unrelated to GERD also. Next slide, please. Okay. How do we diagnose refractory GERD? We will go to the diagnostic testing only. Postprandial high resolution diagnostic methods, actually. Postprandial high resolution esophageal manometry. When we are talking about weakly acidic or non-acidic reflux, this is going to help us. Barium swallow, upper GI endoscopy. When we see hiatus hernia, all these things can be seen in upper esophageal endoscopy only. Hypotensive LUS, again, this is seen in, we will be able to see this in manometry. Reduced esophageal contractility, again, manometry is going to help us. Most of the time, whenever we have to diagnose refractory GERD, manometry is going to help us. Next slide, please. Increased mucosal permeability, again, we need to do impedance testing along with your normal manometry. pH impedance testing should be done. And when we are suspecting persistent esophageal acid exposure, even on double dose PPI, we need to do pH and impedance testing. And delayed gastric emptying, we will be able to diagnose by gastric emptying studies. Endoscopy and small bowel follow through also may help. Next slide, please. So this is the algorithm. Troublesome GERD symptoms despite single dose PPI. 8 weeks of double assess for objective GERD despite double dose PPA. If there is any erosive disease on endoscopy, is first what we do, and pH impedance on PPI therapy with elevated acid exposure time and reflex burden. Obviously, 8 weeks of double dose PPI, and then we do an endoscopy to assess the severity again. And if we don't see anything, we do a pH and impedance. pH manometry with impedance is important. Then we make a diagnosis of PPI refractory GERD. Next slide, please. So, how do we manage PPI with refractory GERD? Most importantly, reinforcing the correct drug intake and doubling PPI dose and high PPI doses. And whether we have to change the PPA formulation. So these are the what we try and do. Next slide. So other things like splitting PPI dosage, switch to a CYP independent PPI, changing PPI molecule or PPI brand. So I am not very sure how many of these are going to help. Let's, I think we should discuss about this. What is your approach for managing refractory GERD? So basically, I would like to do to exclude all these things like coexisting conditions like hiatus hernia, whether there is any gastroparesis related, whether we are looking at non-acidic reflex, we will do pH and impedance manometry. And finally, is it associated with IBS? This is the most common thing most common association what we see reflects with IBS. So first we try to analyze all these things, and then based on that, we will have to tailor our treatment in refractory GERD is what I feel. Comments from the forum, please.
Dr. Somshekhar, you suggested that changing the PPI molecule can sometimes help in one of the slides. What is your personal experience in changing the molecule has helped any patient in your experience? On mute.
So Somshekhar, we are not able to hear you. Sir, you are on mute. Dr. Somshekhar, am I audible?
Yes, we are able to see Dr. Somshekhar, but probably
It's on mute, sir.
Dr. Ishan, you can try unmuting him as admin.
Yeah, I got it. I got back. I had some problem with the. Sir. I was not able to hear you properly, so I was trying to change my audio connections.
Okay. Now, what I asked is in one of the slides, there was a mention that changing the PPI molecule can sometimes help such patients with refractory GERD. So, what is your experience whenever have you tried changing the PPI molecules and that has helped?
I tried there, but definitely it did not help much.
Right. I remember one patient who came to me saying that they don't tolerate they don't tolerate rabeprazole. So I just shifted them to esomeprazole or
Esomeprazole. I
and
didn't have this experience with rabeprazole as esomeprazole, but I forgot the name, sir. It is, I mean, we are not using these days. Long back, this was like 7-8 years ago. I tried a new PPA which came at that point of time, but they said it is not at all helping me, and I don't even remember the name of that PPA which we are no more using at this point of time.
but there was one PPI molecule which didn't work that well and then was ultimately withdrawn.
Yes, sir. Yeah, I forgot the name already.
And
Except
sometimes
that,
dexlansoprazole I'm using sometimes
uh,
for such patients, 60 milligrams of dexlansoprazole, and I found better than the existing PPIs, especially patients who have already taken PPI for a very long time.
maybe they become refractory to single type of PPI is what I feel. They when they change, they feel little better for a few days, but they come
Correct.
back again.
I think it's more of a psychological issue that they feel like a placebo effect. They feel that changing the molecule has helped, probably.
Agree, sir. I agree with. The next question was: would you prefer to de-prescribe PPI or co-prescribe with another acid suppressant or acid neutralizer? Definitely, my answer would be we will co-prescribe another acid suppressant or acid neutralizer than de-prescribe PPA when we are thinking it is refractory GERD.
Sure.
Should we go to the next slide?
Yes.
So what should be the ideal process of PPA de-prescription? So decrease the dose gradually, stop and use on demand, stop PPA completely, less harmful than unnecessary high doses. 1 in 10 patients report relapse after stopping the use. So basically, okay, I don't think this part should be, when we are talking about de-prescription, I don't think we should be talking when we are talking about refractory GERD, at least at this point of time. Definitely, PPA de-prescription is a topic which we have to discuss. And my strategy is I will slowly decrease the dose of PPA and ask them to take on demand if at all we are trying to de-prescribe PPA. So, okay, yeah, we came back to our refractory GERD management, pharmacological management, persistent acid reflux, optimize PPI therapy and add mucosal protective agents or alginates or short H2RA course and or potassium channel blockers. When there is persistently weakly acid reflux, we try to use sucralfate, baclofen, or alginates and any other mucosal protective agents. Pharmacological methods, definitely diet and lifestyle management. This is very, very important. Asking them to lose weight, post correction, avoid smoking, avoid alcohol, caffeine, and other irritants. Surgical management, obviously, laparoscopic fundoplication, and recently we are doing endoscopic fundoplications also. Wherever necessary, definitely yes. Next slide, please. Okay. Talking about the unmet need in management of GERD. In the recent systematic literature review, it was reported that breakthrough symptoms after PPI treatment were found in 30 to 60%. Although PPIs have satisfactory therapeutic effects for heartburn and relative therapeutic gain for regurgitation obtained by PPI, it is evidently lower than the therapeutic gain for heartburn. In these cases, we add on alginate, which helps in reducing reflex symptoms in patients with an insufficient response to PPIs. This effect is particularly high in patients with weak acid or non-acid reflux. Definitely, yes. I mean, most of the time, I think all of us are practicing this part already. Next slide, please. Yeah. Many patients continue to take proton pump inhibitors beyond the recommended course of treatment, and this has potential for harm and large economic implications. Yeah. And PPAs, we will just discuss this part so that PPAs, just one slide back, please. We will talk about. PPAs are often viewed as safe and well-tolerated medications. And while the incidence of side effects such as diarrhea, impaired B12 absorption, hypomagnesemia, Clostridium difficile infection, hip fractures, and pneumonia might be small, older people might be at a higher risk of these conditions. So we can't take this lightly. In countries like India, where medications are available left and right, everyone will take a tablet, calling it as a gas tablet. Definitely, it is our responsibility to decrease the use of PPI and discourage the use of chronic PPI usage. Next slide, please. So again, this is a point for discussion. When do you decide to choose an alternative for PPI, and what do you feel is the role of alginates while deprescribing PPI? So today, whole day, we are saying the same thing. Definitely, whenever there is a possibility, to decrease or stop PPI, and if we can manage people with alginates, that would be the definitely preferred way to manage all these patients. So because alginates, even in a long-term use, they doesn't have any side effects even when we compare to PPA. Whenever possible, definitely I think we have to start using alginates. This is my take on this.
So I'll move on to the next slide. So,
Okay. Role of alginates in refractory GERD. These are the guidelines here. Southeast Asian consensus recommends sodium alginates as first-line therapy in management of mild to moderate GERD. It can also be added to PPI in case of partial response to PPI. I think all of us will agree with this. We are also okay with this.
Correct.
So next slide, please. Yeah. WHO guidelines. Alginates may help in immediate symptomatic relief and in case of unavailability of H2RA and PPIs. Combination of alginate and antacid is superior to that of antacid alone. So what is the significance of alginates in refractory GERD? Alginate has a unique mode of action producing raft formation, and this effect is fast. Alginate monotherapy is a preferable option for treatment of mild GERD symptoms. Yes. In patients with severe or breakthrough symptoms in PPI unresponsive GERD, alginates can be used in combination with PPI to improve symptoms and to reduce reflux events. Although more data is needed, efficacy in regurgitation dominant GERD is possibly higher with alginates. And treatment of GERD in children, alginates have a proven and efficient, effective, and are safe. And alginates can be used in pregnancy and lactation as the first line therapy. So a lot of advantages definitely for alginates here. All of us can see them here. Next slide, please. So, we are running out of time. We can discuss after the next topic maybe.
Yes, sir. Thank you, sir. So I think we'll just have a small poll, and I think because we are running short of time, we'll just get through the rest of it very fast. Melroy, can we just have the polls now? So we'll just keep it to 30 seconds so that we won't. You need to take the sharing rights up, I think, Melroy, before you can start. Can alginates be considered for empirical treatment? Mild to moderate symptom of acid reflux. We can close the poll, I think. What is the percentage of patients on PPIs having refractory GERD in your clinical practice? We can close the poll. We can close the poll, man.
Should alginates be used as adjunctive therapy for relief of GERD symptoms partially responsive to PPI? We can end this poll. We can close the poll. We close the poll. We'll have the last question and then we'll move to the next one. Which property of alginate antacid would be most significant for patients suffering from nocturnal acid reflux? And this poll. Thank you, Melrod. Dr. Vedant, to the interest of time, I'll be just running through the slides last on the topic of GERD in pregnancy.
Okay.
I try to finish within 10 minutes so that can just close it by another 10 15 minutes of the closing session. I hope that's okay.
Sure.
Good afternoon again. We'll move to the last topic of discussion for today, that is management of GERD in pregnancy. So GERD is one of the most common GI disorders which is seen in pregnancy, with almost like 40 to 50% of the women experiencing it. It usually starts during the first trimester and eventually progresses throughout the course of pregnancy, which significantly affects the quality of life in pregnant women. Coming to the pathophysiology of GERD in pregnancy, mainly pathophysiology is broadly classified into two main factors which are responsible for this. One is a physical factor, which is mainly the enlarged uterus size, which increase the intra-abdominal pressure, thereby increasing the pressure on the stomach, leading to a reflux. Hormonal factors mainly include the increased progesterone levels, which causes increased or higher relaxation of the lower esophageal sphincter, leading to decreased gastric emptying and decreased esophageal movements. Also, these hormones affect the enteric nervous system functioning, leading to decreased gastric motility. What are the risk factors which are associated for GERD, especially in pregnancy? Is pregnancy at a very early age. If there is any history of reflux before or during any prior pregnancies. Food which mainly includes caffeinated beverages, spicy or fatty food, alcohol and tobacco, certain medications, and also faulty eating habits, which can be a cause for GERD. Coming to the management, the approach to the management of GERD is broadly classified into two types. One is a conservative approach. The second one is a pharmacological approach. We say conservative approach. It is the most commonly practiced for any, and it is the first line of treatment for mild symptoms, which mainly influence the lifestyle modifications and avoidance of triggers. So coming to the conservative approach, which includes mainly having smaller meals or frequent meals at the 3-hour intervals, avoiding food or late dinner, that is avoiding eating late at night, elevating the head end of the bed and lying on the left side, sitting up straight and walking for 1 hour after meals, avoiding drinking water while eating, and also avoiding the such as chocolate, fatty, oily food, acidic drinks, food, caffeine, etc. I just wanted to take an opinion on this. How frequently is the smaller meals with 3-hour intervals practiced in clinics? I wanted to know of the panelists' opinion on this. Is it routinely practiced at a 3-hour interval and also working for 1 hour after meals? Are these things feasible in clinical practice?
I suggest it should take every 2 hour meal, in fact, a very small quantity. I counsel them that the pregnancy is a precious period, and then if they take a small quantity 2 hourly meals, that is more better. 2 to 3 hourly, that is what I suggest. Rather than taking proper meals like lunch and dinner, take small meals, that is better. And sitting up straight after the meals is a very good practice. Maybe they can read books or something. In the pregnancy, I suggest that they should walk around 10 minutes maximum. A very slow walk after the meals. That is sufficient.
Anybody else want to add on this? I think we'll move on to the next one. What are the pharmacological treatments available for us? Available for treatment of GERD in pregnancy, it mainly includes antacids, mucosal protectants like cipralpate, H2RAs like cimetidine, ranitidine, PPIs like omeprazole, pantoprazole, rabeprazole, and dopamine antagonists, metoclopramide, and RAF-forming agents, alginates. What is the role of alginate-based therapies in pregnancy? So mainly alginate-based therapies are mainly used in pregnancy due to its a non-systemic mode of action because it's an inert substance and it has limited maternal absorption. It has been considered safe for use because of its inert action again, and it has a rapid onset of action followed by the low metabolism because it's not systemically absorbed. I just wanted to quote a study by Strugala et al., which mainly compared the safety and efficacy of RAF-forming alginate reflexoppressant for the treatment of heartburn during pregnancy. This was a multi-center prospective open-label study, which was done in pregnant women with less than 38 weeks of gestation and between the age of 18 to 40 years. It mainly included pregnant women with symptoms of heartburn or reflux or who have had heartburn within the past 72 hours. The main intervention here given was alginate oral suspension was given at a dose of 10 to 20 ml, and the severity of the symptoms at both daytime and nocturnal were considered after 4 weeks of treatment along with the safety profile. Mainly, they looked into the symptom frequency and also the severity. this was again broken down into daytime symptom frequency and daytime severity, nighttime frequency, nighttime severity. They were again classified into very mild to very severe. And the results stated that in most of the women, the symptoms were more during the nighttime and when compared to the daytime. And I'll just go into the detail that is around 67% of the women reported a relief within 10 minutes of taking the medication, that is alginate suspension. And 91% of the women reported that there was a relief of symptoms within 20 minutes of taking the intervention. So this medication of alginate reflex suppressant was found to be safe and tolerable in mothers as well as the fetus. The study also looked into the efficacy of the drug based on the investigator rate and also the patient analysis, which said that around 90 to 91% of investigator and patients said that the efficacy was good to very good. 90 to 91% of the patients had very good efficacy. So the conclusion from the study was that the alginate-based suspension was found to be highly efficacious and safe for treating heartburn and reflux symptoms in pregnant women. So we'll just move into the discussion aspect of this. In your routine practice, which pharmacological approach would you take to manage acid reflux in pregnancy? I would request, because it's the last closing the session in another 5-10 minutes, I request all the panelists to voice their opinion here. If possible, you can switch on your cameras and that would be more helpful. Dr. Gautam, your opinion on this?
During pregnancy, personally, I have not used any alginate formations as of now. So still, I'm the patient. If they have serious symptoms, I am still continuing low dose PPS. As of now, I don't have any other experience on.
Somsekhar. Dr. Siddharth. Dr. Vedant, any comments from your side?
I'll take the final thing. As the other gastroenterologists have suggested, we deal with very less patients with pregnancy coming to us, and most of these patients, the pregnant patients, are under care of the gynecologist, who has already prescribed them an PPI. And when the PPI doesn't suffice, then they come approach us. And when they approach us, I just add alginate. I have few patients, not very many, who I have tried alginates, and they have responded very good. Especially the treatment has been revolutionized in last 2-3 years when alginates have become very commonly available in the Indian market. And earlier also I was using alginates in these patients, then very less frequent. So they are getting better symptomatic relief, and we were able to avoid prokinetics in this such patients group with the just PPI and alginates. Plain alginates in patients with pregnancy, I don't have experience right now. Thank you.
So just as per the article published in BMC Gastroenterology, usually they start with the lifestyle and dietary modification, which is more of a conservative therapy and with non-systemic therapies, followed by sucralfate, then the H2 receptor antagonist, PPIs, along with PCAPs, and then later endoscopy is usually done. This just wanted to know the opinion also. Do you consider the FDA pregnancy categories before prescribing for acid reflux management?
Of course.
The Somsekhar. So mainly the drugs which I've already discussed, mainly antacids and sucralfate. Most of them are being comes under FDA category B, which is omeprazole, which has shown some embryotoxin, fetotoxin in animals. And alginates are mainly considered to be there are no safety concerns for the mother or fetus, and the data available says there is no side effects seen in the mother or the fetus. Just to talk on the role of alginates here, alginate antacids mainly in combination. Sodium bicarbonate component for releases carbon dioxide within the alginate gel, leading it to floating off the alginate within the for the top of the food content. And this alginate antacid wrap forms a non-systemic barrier over the postprandial acid pocket, which reduces the postprandial acid reflux. And because of its physical non-systemic mode of action, alginates are safe during pregnancy. Just before we close this topic, just wanted to know opinion for how long do you continue the treatment and what dosage for pregnant women suffering from acid reflux?
I think the pregnant females are nothing different than other patients. We need to follow the same strategies, but then I discourage always use of long-term any kind of acid reflux therapies. Maybe it is a PPI or maybe even alginates. I tell them to continue for some certain period, and once the need suffices, I tell them to switch over to SOS form of alginates. That works well actually. They really don't have, especially first trimester, they will have too many complaints. Second trimester, I don't think so. Most of the pregnant females are doing okay, and especially if they don't have any kind of underlying or pre-existing GERD issues, then most of these females will do extremely well in the second trimester. Third trimester, because of the pressure symptoms, many of them develop the reflux issues, and I normally tell them to just take alginates on SOS basis, and the need suffices.
Dr. Gautam, you want to add anything?
We have more slides to present, Dr.
No,
Ishan.
sir, this is the last one. So just wanted to, before we close it down.
Because we'll have to wind up soon. I'll have to
Yes.
rush for the hospital now. So
we are done with the slides. Just we are done with the slides. Before we go out, can we have a closing remark from everyone? Dr. Amit, could we start with you before we close the session? Dr. Vedant, can we have a closing remark from you and then we'll close the session?
to summarize with today's session, we had a good discussion on GERD, especially from the alginates perspective, and we discussed on various aspects today. First was the nocturnal acid reflux by Dr. Gautam, which will enlighten us with a very good few of the recent updates, which were very nice. And I think we should more commonly use alginates in the patients who have a nocturnal acid reflux. And followed by Dr. Somshekhar's talk on refractory GERD, which we encounter very commonly in our practice. So we got a very nice insight that we should be definitely using shifting to alginates along with PPIs, patients with refractory GERD. And of course, prokinetic usage, which is very rampant in our Indian society, Indian market, and then it has to be discouraged, which is a common practice among all the doctors, prescribe prokinetics along with the PPIs. And we just discussed about the two more topics Dr. Ishanu just spoken about. It is about the postprandial acid reflux and also GERD during pregnancy. Very important takeaway point message is that patients who are especially pregnant, they are very afraid of taking all medicines. So we should reassure them that alginates are safe and can be definitely be used on a SOS basis, or maybe in the regular use initially, and maybe subsequently on a SOS basis for patients with pregnancy. We also had a very good discussion upon the H. pylori, H. pylori related treatment, and maybe we can have a more discussion on that in our next talk. So to conclude, we had a very good discussion. Thank you all panelists who participate in this today's talk, and thank you Abbott for giving us an opportunity for having this kind of good discussion. And of course, we would be very happy to have more such discussion, maybe more on a wider perspective related with GERD. Thank you.
Sure, sir. We'll think or we'll look into it, so we can have a new voice. Going ahead, we can plan further meetings with more discussion on GRD and its management. Again, I'd just like to thank Dr. Vedanta for his cooperation. Basically, even though due to his busy practice, even then he coordinated with us, even though it was a last minute change that he. Thank you very much, sir, for accepting our invite and to be the chairperson for this session. Thank you very much,
Most
and
welcome.
for the excellent moderation of the session. I'd like to also thank Dr. Gautam and Dr. Somsekhar sir for your excellent talk, and also the rest of the panelists who have provided their insights during this session. We'll be in touch with you, and we'll be sharing the meeting minutes of meeting with you in the coming days. Have a great Sunday and take care, everyone. Thank you
Thank you,
very
everyone.
much.
Thank you. Bye bye.